Well, thank you so much. I'm very pleased to be here, and thanks for coming out on Sunday morning. I've been pleased to be involved previously with NSTA, and it's been a number of years, but I have the greatest respect for what this institute, this organization is doing. And as a neurosurgeon that does deep brain stimulation, I think it's an important option for people to consider, particularly with various forms of dystonia. Anyway, a lot of what I'm going to start with is sort of the more generalized dystonias, because of course that's where DBS was originally looked at. And only sort of, then at the end I'll come to cervical dystonia or spasmodic torticollis, which of course is the topic of this organization, but I want to give you the overview of how we got to this point with the treatment. So the first thing is, and this I'm going to kind of skip through pretty quickly because of course yesterday you had all these great talks from the neurologists about dystonia, and all of those people are here very familiar with this. But it's a common mood disorder, and it involves of course involuntary muscle contractions, producing painful, sometimes painful but abnormal postures, and sometimes abnormal movements as well. And there's various forms of dystonia, as we know. It can affect any body part, any area of the body, sometimes half of the body, so-called hemidystonia, or the neck as cervical dystonia. And what's interesting is, and this is where there's an interesting overlap with things like Parkinson's disease and essential tremor and things. It's thought to be that it may originate from abnormalities in structures in the brain called the basal ganglia, which we'll talk about in a moment, which is part of what's called the deep brain extrapyramidal motor system. In other words, it's a group of structures deep in the brain that tend to modulate motion. And that's this whole concept down here, thought to be involved in what they call scaling and focusing of movement, meaning kind of like really honing the movement. So you do a movement, but then the actual amount of that movement and the amount the muscle contracts and things, of course, is calibrated. So that's really, obviously then the idea in dystonia is it's not calibrated properly in some patients. Okay. Well, this is the part I'm going to skip through because of course this is really very well described by the neurologists. From a neurosurgeon standpoint, I want to understand in a most basic way, not all the details necessarily of all the medical treatments that the neurologists are doing, but I need to understand the categorization, and I need to understand where the surgery may be useful in particular cases. So primary versus secondary is the first sort of categorization. Primary, of course, is more like, this is the genetic type syndromes for dystonia. And again, we're not talking specifically here about spasmodic torticollis, I realize that, we'll get to that. And secondary is more like after something has happened to the brain, such as stroke or trauma, can lead to what we call secondary dystonias, and those are treated a little bit differently than the primary. Age of onset is important. Some of the early onset dystonias, the genetic dystonias, can occur very early in life, as many of you know, I'm sure. And then body distribution, is it focal, as in a focal dystonia, cervical dystonia? Is it multifocal, multiple muscle groups? Is it segmental, meaning a certain segment of the body? Is it the half of the body, or is it the whole body? So those two kind of basic categories. I'm not going to, this is just to show that there are genetic forms of dystonia, and of course that's not totally relevant to this talk, but it's really just important because we want to get genetic diagnoses on people if we can for these types of syndromes. And it also helps understand other forms of treatment that are coming down the line. The DYT gene group, which you can see goes from like 1 to 15, a group of genetic forms of dystonia. And there's some information that DBS may work slightly better in some studies for the genetic forms than for the non-genetic forms, but that's also information that needs to be improved. Obviously in this group we're really concerned with cervical dystonia or spasmodic torticollis specifically, which is a form of segmental dystonia, as you know very well, affecting cervical musculature, various forms. And obviously one other thing that's really interesting that you're of course aware of, and which was I'm sure covered yesterday by the neurologist, is cervical dystonia or spasmodic torticollis itself has various categorizations, such as things like, where is the which muscle groups are affected. For example, anterocollis versus lateralis versus retrocalis versus torsional movements. And what's still unclear in the literature, and this is as of at least what I've reviewed up through last night, is whether these categorizations within cervical dystonia are separately responsive to DBS. We have studies that I'll show you where DBS helps in general, but not necessarily in these subcategories. So that's of interest as well. These other categories that I'm not going to really talk more about, although if you're interested, for example, there's some interesting literature on Meye's syndrome, which is the so-called idiopathic cranial cervical dystonia. To those who have interest in that, I'm very happy to provide more information, but I kind of took the slides out of this presentation for that. But there is DBS for Meye's syndrome as well, for example. Treatment, of course, this was covered well, and I saw Dr. Pathak and Dr. Fry's and Dr. Duane's slides. So, of course, botulinum toxin is the primary form of treatment administered directly into the muscle, and obviously that's the idea for both the focal and the segmental dystonias. Obviously, if you get into generalized dystonia, it's not like you're going to put Botox in every muscle in the body, right? So this is obviously a bigger or different issue. Although drugs, systemically acting drugs such as benzodiazepines like Valium and those types of drugs and baclofen have been used to try to generally relax muscles, but as you can imagine, those in many cases are not all that effective in generalized dystonias. And then there have been a history of what we call lesioning procedures, which is sort of old literature now, and in other words, actually making small lesions in the brain in specific structures. And this is something that has a bit of a checkered history, as you can imagine, all the way back to frontal lobotomies and things that are in the past. But there are still some roles for things. For example, obviously denervation for the purposes of, like, for example, selective peripheral denervation, still a procedure that's performed, although quite honestly fewer and fewer neurosurgeons are trained to do it. You might know that already. There's denervation procedures. But the idea in sort of 2019 in my field, in neurosurgery, of making a damage in a nerve, whether that's in a nerve or in the brain, is really, we want to relegate that to the past. That's sort of where we are psychologically in the field. We think that, anything pre-2000, which is already 19 years ago, that's when I started training in this field around 1999, that's where the literature shifted into DBS. It was really the early 2000s, and that's really where we want to be. For a variety of reasons, DBS is adjustable. If you find the right target and the right person, turn it up and down, it's much more adjustable, and of course not lesioning the brain, not causing damage in the brain, and that's really an important issue. And that's really what I was just discussing, like what is the role of DBS? What's clear in other disorders like Parkinson's and tremor, who would have had tens of thousands of people implanted, is that it works. There's lots more studies. In dystonia, it's increasing, and we'll see those studies in just a minute. About what is DBS, and the video here is just designed to show, for those of you who aren't as familiar with it, the concept of that there's these deep brain structures, and this is what we call the basal ganglia, these structures sitting here in the deeper part of the brain, and specifically we'll talk about a little bit more of the anatomy in just a minute, but the idea is that the electrodes are placed very precisely, and they're very thin electrodes. We're not trying to damage anything, just to get there, and stimulate specifically structures deep in the brain with electrical stimulation. Not shown here, these electrodes are connected by, okay, there they are, the wires coming down, and then the wires are of course connected to a pacemaker, so-called pulse generator, which is basically a battery. That sits in the skin under the chest. So it's what we call the brain pacemaker, and again, it's been used for many years for tremor and Parkinson's disease, and also now for dystonia since early 2000s. The principles here are that the thin electrode is placed in the deep structure. It's attached to the pulse generator. The stimulation is adjusted by the experienced person. Now this can be a nurse practitioner, it can be a neurologist. It's obviously often the company representative from the company that makes the device, but the key is to have someone experienced in doing these types of stimulator programmings. And the idea is that the electrical stimulation reversibly, meaning you can turn it on and off, alters the function of the brain tissue in the region of the electrode. So then that brings up the question, well, how do you know where to put it? And I'll get to that in a moment. These are the other components of the system, so or the components of the system. So you have the electrode itself, which is the thin wire, basically the size of a spaghetti noodle, sitting in the brain, specifically in that structure of interest we'll come to in a moment. And then it's connected, there's a little cap on the surface here so that it doesn't move. That's important, as you're moving around, especially if you have dystonia and other things. Just living normal life, you don't want the thing moving. So that's actually clamped at the head, so the little connection there. This is important because I have some people that go through this procedure and then 3 months later they get into a car accident, unfortunately. We have to be as careful as possible that the thing doesn't move. The extension wire, which comes through the neck, that's under the skin, and then it goes down to the battery. So it's really three components, the so-called the lead, which is the electrode, the extension cable, and the pulse generator. I promised you some brain anatomy, which is what I'm interested in. May not be interested to you, but hopefully it does a little bit. The deep structures of the brain here are in this picture colored. Now what this is kind of what we call a coronal picture, which is kind of top down. This is the top, this is the bottom, and then the right and the left. What you see in these things is these little structures, and believe it or not, each of these structures does a completely different thing. So, and this is even a blow-up of that. So we look at a structure, for example, called the GPI, which is the primary target of the brain for dystonia. It's called the globus pallidus, internal segment of the globus pallidus, or GPI. And you'll notice outside of that is something called the GPE, and then there's the putamen, the thalamus, the caudate, all these other structures. The STN, which is a target primarily in Parkinson's disease for DBS. Although it has been used in a subset of studies for dystonia, but GPI tends to be the one that works better. Anyway, all these structures are kind of grouped together in the so-called deep brain area. And when we target, meaning try to place an electrode in that structure, we have to be very careful of what structures we're going through to get there. And in fact, we use that to map the brain during the surgery, as I'll describe, to get to the GPI and make sure we're in the GPI 100% of the time. So what are the stages of the surgery, and then we can discuss the outcome results in the literature. So the way that DBS is done, and this is done the same way whether it's for dystonia or for Parkinson's disease or for essential tremor, which are the predominant three uses that DBS has currently for movement disorders. The first thing is we get a preoperative MRI, and that's of course to get a detailed picture of the brain. Now that's actually much more detailed than your standard brain MRI. So if you go into a hospital and get a brain MRI or something, this is actually much more detailed than that. It's called a DBS protocol MRI. So we're looking specifically in detail at those middle brain structures. Then the person undergoes first placement of a frame, which looks pretty scary. The thing is, this is all done with sedation, meaning you get sedated and there's a ton of local anesthetic. The main thing here is, we could discuss all the details if you have questions, we want to make sure people are completely comfortable. This is the most important thing. So people are not feeling any pain. It's all completely numbed up. We then get what's called a stereotactic CT in the frame, which means that we get a scan with the frame and the head together. That enables us to computationally put that information into a computer in the operating room, a workstation, that fuses the MRI to the CT. In other words, the preoperative MRI with all the anatomic information is then fused to the CT with the frame information. That gives us a three-dimensional way to do something we call stereotaxing. And that's the basic principle of using the external coordinate system, which is the frame, along with the brain image, which is the preoperative MRI, to accurately target the deep structures in the brain through a small opening. It's my job to be able to get electrodes into the brain with sub-millimeter accuracy. And what sub-millimeter accuracy means is that I cannot even be off by a millimeter. We have to be off by sub-millimeter. In other words, we have to be within a millimeter of the target. And why is that? Because it turns out, if you go back, if I have the electrode in the STN instead of the GPI, or the GPE instead of the GPI, or the putamen or something like that, it's not going to work. That's the bottom line. So these structures are very specific, all these little pathways. We have to be stimulating the pathway we think, otherwise Otherwise, I put the electrode in the wrong place, and then the neurologist is very unhappy, as is the patient, because it doesn't work. So my job is to put it in the right place, carefully and safely, and that's where this concept comes in. Once the electrode's in place, then we can actually test it with the person awake. That sounds pretty dramatic, but you probably some of you may have seen these videos. They're all available on YouTube, where basically people are feeling no pain. The pain is on the scalp, which is all numbed up. The brain itself feels no pain, so you can have this electrode in place and have the patient awake, and they're not feeling any pain. In fact, they're able to talk to you and do various things. So we like to see, in the case of GPI, we stimulate it and see whether muscles loosen up and things of that nature, based on the person's symptoms. Once we're convinced the placement is good, then we sort of suture everything up and close in. The procedure itself is about an hour and a half. Patients awake for about 20 minutes only, so we don't want to keep people awake too long during the time when their head is fixed. But that's basically how it works. The electrode ends up, and I know it may be a little bit hard to see in the back here, but these red circles are around this sort of mirror image where the electrodes end up, and this is called the GPI. So that's what it looks like. That's the target on the MRI. So you can see the trajectory to it is like basically from the top down like that. We have anatomical landmarks, which is of course the most important thing. So we know the center of the brain is here, and these are the two dots on the side, just like I showed you on the MRI, where we want to place the electrode. And we specifically want it about that position within the GPI so it doesn't cause side effects. What's interesting also about this is if the electrode's in the wrong place, it will cause things like twitching of the mouth or numbness and tingling and stuff as you turn it up. So we test it to make sure it's in the right location. The other thing we do, which is actually quite interesting to me, is that we can listen to people's brains, and on the way down, each structure sounds different. In other words, we have a thin wire electrode that's be able to listen to this firing of the brain structures as the person is awake. And once we get to the GPI, it has this massively synchronous firing of the neurons, and we can see exactly where we are. So that's what we call microelectrode recording, and that's in order to make sure we're in the right place also. Okay, so the procedure's done, and then at a later stage, usually we do it a week later, we put in the battery. Everything's healed up, person's had the procedure. Now they go to the outpatient setting with the neurologist, and the important part there is programming. And programming is basically done non-invasively through a programmer, which is like a little magnetic thing that's held over the chest, over that battery, and it communicates through the skin, and it can turn up and down the stimulation. And as you might have seen, let me see if I can go back to it. The electrodes themselves, yeah. If you look at the electrodes themselves, there's multiple contacts on the electrodes, and those can be selected independently. So for example, if they're called 0, 1, 2, and 3 here, for example, you can stimulate between 0 and 1 for a small little area of stimulation, or you can stimulate 0 to 3 for a larger stimulation. And so what's called the current density and stuff around the electrode can be adjusted, and they have ways to sort of systematically do that during the programming session. So, so the idea here at the postoperative visit, initial programming visit, is to get the post-symptom suppression of the dystonic movements and or postures. That's really the goal, of course, of this form of treatment, and minimize side effects. And then that's through manipulating the electrical field. And then, of course, you want to stimulate at the lowest voltage so that you have increased battery life. These batteries last anywhere between 1 year and 5 years, depending on how often it's used, how much it's used. Sometimes it can go pretty quickly if someone has high settings. Newer batteries in this field are getting better, so that's one thing that's improving. So the advantages of DBS are, first of all, it's adjustable. As diseases progress, it can be changed. As medications change, the DBS can also be adjusted, and then we can manipulate the side effect profile. And it's reversible, and as we discussed, it doesn't lesion the brain. So at least in that sense, it's much preferable to all the older procedures on the brain. What are some potential disadvantages of this treatment? Well, there's potential complications of surgery. That's very clear, so we need to talk about that for at least a minute, and I'm happy to answer any more questions about the details of this. Any type of procedure is associated with the risks of bleeding and infection. That's just the reality of surgery, and we of course try to minimize that. We take people off blood thinners if someone's on aspirin or Coumadin or something very unsafe to undergo this. Out of 100, we are having a complication of bleeding, causing some damage to the brain. That's the most serious risk. So up front, I'll just tell you that's the most serious risk. Everything else can be dealt with, including infection, lead breakage, all that stuff can be fixed. What can't be fixed is if there's damage to the brain. So that's what I tell people up front, it's a 1% risk of serious complication from this procedure. And what's interesting is we know that number pretty well because of tens of thousands of people that have gone through this procedure, and you look at all the studies, it's pretty similar between all the studies. And then we can also look at that in our center. I've been doing DBS here since 2010 at Orange Coast Hospital next door, and that's almost exactly what our numbers are. So we're basically the same as the national and international numbers. Infection obviously is one of those things that can occur. If it happens, then you have to give antibiotics, potentially remove the system and replace it at a later time. It turns out that over the past 10 years, or 9 years here, we've only had to take 2 systems out and replace them for infection. In both cases, the patient had antibiotics for 3 months, completely eliminated the infection, but had to take it out, put it in later. In other words, put a new system in later, and they're both doing fine. So I see infection as a major nuisance, but not as a life-threatening thing, and it's never threatened actually having the procedure done. Hardware malfunction, I mentioned that some people may have some unfortunate thing like a car accident 3 months after the procedure, and I had a couple of patients where they had a whiplash type injury from an accident, and that actually fractured the extension wire, and both of those patients needed to have that extension wire replaced. And after that they were fine, but that's another thing that can happen. So these are sort of issues with surgery. And then there's also potential stimulation side effects. So if the neurologist has the stimulation up too high or in the wrong configuration, there can be weight gain, there can be unexpected cognitive and psychiatric changes, there can sometimes be tingling, numbness, things like this. The good news there is they're not real complications, they just need to be adjusted in terms of stimulation reprogramming. So if someone's having those things, that can be eliminated by adjusting stimulation. It is the case that reprogramming is often required, especially up front, because people will start to say, well, I have, for example, I had a patient recently where, oh yeah, my tremor's gone, but I have this weird taste in my mouth. And then he got readjusted, and then the tremor was fine, and then taste in the mouth went away. So it was clearly something interesting about how the stimulation was overlapping the taste area in the brain. So these types of interesting things are, of course, troubling to people when they happen, so we have to fix those things. And this is largely done, obviously, all of this part is done at the neurologist office. Cosmetically, what does DBS look like? Well, we can't get around the fact that there's a bump on the head. Usually the hair, well, of course, the hair goes over. For people who have hair to grow over it goes over, and it's right up here. It's usually behind the hairline. Even in balding men, it's usually behind the hairline. So anyway, that's sort of one thing. And then there's the wire underneath the skin, and then the pacemaker in the chest. So, most people, honestly, that are going through DBS, they're much less concerned about cosmetic issues. But just to mention it, so there's definitely a bump in the chest, and there's definitely a bump on the head after this treatment. Let me move to this outcome studies, because I want to sort of get through those and then answer your questions. And these are, I want to give you sort of 2 grading scales just to give you an idea of how these things are done. Many of you may already be familiar with this. If you look at generalized dystonias, so dystonias that affect the whole body, they've used something called the BFM-DRS, which stands for the neurologists that named this thing, Burke Van Marsden Dystonia Rating Scale. And the idea is that this is for generalized dystonia, not for spasmodic torticollis, but and we don't have to go through all the details, but basically the higher score means that there's worse symptom severity, and no dystonia at all would be a 0. So basically what we're looking for then in these studies is a BFM-DRS score reduction with treatment. So the idea is, and we'll look at percentages. So what percent score reduction are we getting in terms of the clinical scores in the BFM-DRS for generalized dystonia after DBS, and in the case of the cervical dystonia, the TWISTER score. This is called the Toronto Western Spasmodic Torticollis Rating Scale. You might already be familiar with it. A lot of the outcome studies are using this. And the idea is that there's several sections. There's severity of symptoms, disability level, and pain level. And of course, as you all know, the spasmodic torticollis can cause all of those three categories of symptoms, both overall severity, level of disability in terms of activities of daily living, and pain. And these things add up with where higher is greater impairment. So again, we're going to look at what % reduction we're getting in these scales. And to summarize, basically, if you do bilateral, and this is always done both sides of the brain, GPI, DBS, leads to about 50 to 70% improvement in BFM DRS. That's again the generalized dystonia studies. And then there's at least 2 class 1, meaning really good randomized controlled trials to support the benefit of DBS. I'll show you those in a moment. And it's been FDA approved, many of you know this, under something called a humanitarian device exemption, which basically means that you can get this for treatment of dystonia. And it's effective in generalized dystonia, and it's less effective for these so-called secondary dystonias like post-stroke, post-trauma, or cerebral palsy. That's for the generalized dystonia category. To show you where this came from. So these are the studies. So this one actually back in 2004. So a lot of this stuff came out in the early 2000s, and that's what led to the FDA saying we can use this as what's called an HDE, humanitarian device exemption. And this is just saying early long-term results from electrical stimulation of GPI with primary generalized dystonia. Again, not spasmodic torticollis yet, but generalized dystonia. And this was for 31 patients in this study. Here's another study which was probably even more influential study. This came out in New England Journal of Medicine in 2005. I'll just show you that. This is details of that study. We're still in the same study, 2005. And this was a French study of 22 patients with generalized dystonia. And to make a long story short, there was a significant improvement in the disability score at 12 months after stimulation. And health and physical functioning improved significantly. The downfall of this study, just from a study design standpoint, is they didn't do what's called sham stimulation. In other words, there could have been a placebo effect from just putting an electrode in somebody. So subsequent studies actually did do what's called sham stimulation. Let me explain what that's like. So this is now this is the same study. 2 years later, they do a 3-year follow-up, and they ask, after the 1-year follow-up that they did with the 51% improvement, did they have maintenance of the effect at 3 years, or did it wear off? And the answer is they still had 58% of people improved, 58% of motor improvement at 3 years. So in other words, it continued to work, and the improved quality of life was persistent. One thing that's important is that this did not appear to change cognition or mood. In other words, it has effect on this motor system, but it doesn't mess up your thinking, it doesn't improve it, doesn't make it worse, it doesn't improve your mood, doesn't make your mood worse, it just has no effect. In studies, you have the disability score. This is the movement score, disability score, and you see this is before surgery, and then 1 and 3 years after. So you get this type of 50% improvement in symptoms, which is quite significant. This is the study I was going to mention, which is now, this is the German, Norwegian, Austrian study, 2006. Multi-center, so centers throughout Europe and these 3 countries, 40 patients. And they all did palatal, meaning GPI stimulation. And they find significant improvements in the neurostimulation group. This study did have what's called a sham group, which means they got surgery, but they didn't get stimulated at the beginning. They later were switched into stimulation, so they, of course, didn't have surgery for no reason. And in fact, they all got benefit at that point. So this is the way that type of thing works. So this is before stimulation. Each of these is a patient. And then after 3 and 6 months after. And you see when you go down like this, your movement score is improving. And you can see most patients, although not all, are improving significantly. And this is the type of summary data. So the bottom line here is that stimulation improved generalized dystonia. Now this was the first study that actually also included some people with segmental dystonia. So now we come into people with cervical spasmodic torticollis were a subset of that study. One other thing they did, which is actually important, is that health-related quality of life assessed by something called the SF36 scale, including things like physical function, body pain, general health, vitality, social function. Other things like this were actually improved in this study, which is new compared to the other study. Neurostimulation had significant increase in these domains at 6 months after stimulation. They had about a 50% improvement in severity and disability. And then but there was no obvious, in a small group of patients, it's hard to get predictors of outcome because of the statistics. But when the dystonia improved, it was associated with improvement in disability, meaning lowered disability and improved quality of life. And there were a few side effects reported, primarily things like infection. Bless you. The next thing, though, that I want to come to, so those were early studies, that was the background I wanted. These early studies were mostly on the generalized dystonia patients. Now let's come into the spasmodic torticollis or cervical dystonia, which is, of course, relevant to the NSTA group. And we have this option for patients who are poor responders to botulinum toxin injections. And we know that there are issues with botulinum toxin injections, particularly over time. People develop tolerance and other things can happen. So the initial results actually were way back, Krauss and colleagues in 1999. I want to show you that. This is just literally the first report of it, and it's almost no patient, I mean, very, very few. This is like literally a case report. Look how many patients, 3 patients. So to give you an idea, when was this started? Just to give you an idea, who did the first study of DBS for spasmodic torticollis for cervical dystonia? It was Joachim Krauss and colleagues, German group, in 1999. So way back in 99, but that was only 3 patients. But if you look at these 3 patients, here's their disability score, which is maximum 60 on their scale, and it went down significantly at a follow-up. So they had all these 3 patients getting a lot better. So that made a lot of people excited about doing bigger studies. Here's a 10-patient study, again, not huge numbers, but bigger than 3, that was reported a few years after that, 2007. And this was 10 patients with cervical dystonia. Again, now we're in a group, it's all spasmodic torticollis. They were treated with bilateral GPI DBS. They were evaluated with the twisters, which is that Toronto Western Spasmodic Torticollis Rating Scale, before surgery and then at 6 and 12 months after. So this was a little bit longer study also. They found that the severity, the disability, and the pain score all improved at 12 months after surgery. And the improvement was in the 43% range. So in other words, about 43% improvement. So not like dramatic, like 90% improvement, but certainly a significant improvement. They also found general health, physical functioning, depression scores did improve in this study. They had some small transient adverse effects such as difficulty swallowing, difficulty speaking in a few patients, which subsequently was adjusted with the stimulation. So this was what I would call a small study, but a significant result. Only 10 patients. I'll skip that. It's sort of a little bit confusing looking at all those lines. Okay. This is a different study, the 10 other patients, also in Canada, and this one actually had a little bit better improvement, about a 55% improvement, with a 59% improvement in disability and a pain improvement by 50%. So again, similar idea of this. And 32 months is a little bit longer, obviously. What is that? That's over 2 years. So they had significant sustained improvement, at least over that time period. And this, again, is back in 2007. I'd like to come to one of the more recent, the most recent larger study, which is in 2014. It was reported, and they're still following these patients up. But this is, again, that Germany, Norway, Austria group where they're looking throughout various countries. And they're getting, in this case, a lot more patients. So this was 62 patients. This is the more recent study. And then they assigned them to either neurostimulation or to sham stimulation. In other words, everybody got the surgery with the bilateral GPI DBS. And then at 3 months after stimulation, so the first 3 months, you either get the surgery plus no stimulation, although you go in and you think you're getting stimulation, but it's sham. So that's how they do these studies. After 3 months, everybody gets stimulation because Otherwise, how are you going to get people to go through surgery and not get stimulation? It doesn't make any sense. So basically, they have the first 3 months they can compare those groups, and then after that, everybody gets stimulation. So reduction in dystonia severity was significantly greater in the neurostimulation group than in the sham group, and that, in other words, it's better than placebo. And then after 6 months after stimulation, the Twister's disability score, that score that we talked about, was reduced by 46%, and the pain by 51%. So again, in the range of what we saw with the other study, but in much larger group of people. So here they are. This is sort of the baseline, or this is the sham stimulation versus active stimulation, and the score going down is better. These are the individual patients after stimulation. One thing that's also clear in these studies is some people have this dramatic effect, where they just have like a 70 to 90% reduction in their symptoms, which is fantastic. You read these little cases and it's wonderful. These people their life is much better. And then you have these other patients where, for example, let's say this patient, where even though they're stimulated, their score hasn't changed. So that's, of course, a question of who are these people, and how do we select better in subsequent studies to get someone who's reduced much better. This would be the idea that during no stimulation period and then during active stimulation period, it gets much better. In summary, where are we with these studies now? So as of late 2019, which I reviewed the literature up till last night, there have been about 50 distinct studies. I'm not showing you 50 studies, I'm showing you the bigger studies. There's been some smaller studies recently that have basically shown the same thing of what I'm showing you. DBS for dystonia is supported by class 1 medical evidence. That means with randomized trials like we've been discussing. And on average, there's about a 65% improvement in dystonia scores. Now that's weighted more by the generalized dystonia. For the cervical dystonia, we're seeing the numbers in the 55% range, like I showed on the recent slide. But significant improvements. And so the idea is in properly selected patients, and that's a good question of exactly how to select, GPI DBS can lead to significant improvements in both generalized and segmental, such as cervical dystonias, and improved quality of life. Every patient, therefore, with dystonia deserves access to a center where they possibly could be considered for this form of treatment, especially after they've, quote unquote, failed or tried other forms of therapy. I want to acknowledge Dr. Trung and Diane also, who have been instrumental in, of course, this whole organization, and also in my practice here at Orange Coast. And that's our practice website. There's a little bit more information there about DBS, those of you who are interested. But I'm happy to answer any questions. Thanks for your attention.